This patient, she's young, right?
Yes,
She's 44,
very young,
right?
44.
And I just thinking, like, what goes through your mind when you see a 44-year-old who has, a supposed ovarian cancer?
So, she's very young, and we haven't any history in terms of extensive comorbid conditions. So that's actually quite important. We really don't have a family history to draw from on here, but you still would be wondering, does she carry a BRCA mutation, whether it be a germline or a somatic mutation? So that's quite important, certainly as some of these studies have evolved at this point in time. And given the fact that, she has a liver lesion, she has a splenic mass, the question is, how is she best served? So it really kind of is put in the hands of a multidisciplinary team, including our surgeons, our medical oncologists, and the like.
So let me ask you, so presumably this patient came and saw you first, probably referral from, somebody who, kind of did the reverse. They saw a patient with symptoms, got a CAT scan, and then referred for a pelvic exam. And then you saw that this is probably a GYN origin. And then what is your natural process to send them to?
The natural process is always to kind of work in conjunction with our gynecological surgical oncologist, because it really is, at the end of the day, the opinion that's rendered in terms of whether it be adjuvant, primary debulking surgery, or neoadjuvant therapy really is made by both the medical oncologist as well, and maybe sometimes radiologist as well as the medical oncologist. Yeah.
Dave?
This is a tough case. She's only 44,
right?
And she has, and we don't know if she has resectable disease or not, right?
But
you can do a spleen. You can have a solitary liver lesion. You have periaortic lymph node. These may all be resectable, depending on what her peritoneal disease looks like. So, I know you at MD Anderson are doing a lot of assessments by laparoscopy. We have much more difficult time doing that at Ohio State and the James Cancer Center because of just the way our practices are set up. But I think, in a 44-year-old, I really want to make sure that we find a reason not to operate on her. And so I think that is important. Now, saying that, this is going to be a big debulking.
Right. Yeah, I was going to say, Shannon, when you're, wasn't that really kind of the whole point of doing the scope, was to try to find the patients that you could get a complete resection in?
Absolutely.
Yeah.
I mean, we use this validated score, and the whole goal of the score is to give you an idea of what your likelihood is of achieving no gross residual disease, which we know, based on multiple retrospective analyses of prospective data, that's where you get the best bang for your buck, right? Those are the patients that live the longest. What we don't know is it really the surgery that does it, or we're just picking those right patients and they just are going to do well no matter what we do? We haven't answered that question, I don't think.
And that's a great question. That's a great point. I think Neil Horwitz's paper looking at some of the GOG data is probably one of the most under-quoted papers. That looking at the complexity of the surgery and the score with regards to their disease. And if you have both a high tumor volume and a high complexity of surgery, they don't do as well. So this is really, but on the other hand, she's 44.
I know.
No, those patients.
So, I often use that paper to justify with the question you just asked, which was, is this biology versus just surgical ability? And in that paper, you can see that the more aggressive surgery, even because of that need for complexity, if you get that patient to the same disease volume, they still do not as well as if they had not had the surgery at all. So, yeah.
But I think a good point also is we're told that she has a solitary liver lesion. We don't know that it's a solitary liver lesion. Oftentimes, this is just a CT scan. We've all known that CTs can often underestimate what volume of disease is there. So that's something to be mindful of.
Good point. So in this case, if you send her to Dave and Dave says, I'm going to operate, you say, well, are there other procedures that you would recommend that she have before you just
you could
release?
always do a PET scan. I'm very fond of an MRI of the liver if you're really looking for more disease in the liver. I mean, you're right. The splenic mass is a doable thing. It's the liver lesion that I think turns me on a different scale. But I would do an MRI of the liver just to be sure that we're not really dealing with more than multifocal disease.
And one thing we've started doing in recurrent, not up front, is the MRI of the peritoneal cavity.
Yeah.
With proper protocols, you can really see what the peritoneal disease, because what's probably going to define this, is the liver, but it's really the peritoneal disease.
Yeah, I agree.
Yeah, those are the things that are really hard to assess. The mesentery is the other thing that I wish we had a better way of assessment.
So, we kind of recently undertook a study amongst our group and compared it against the radiologists to see who could do a better job of defining who these people are. I don't know, what's your sense of that?
I think it's a crapshoot based on who you see.
Yeah.
I think it's based there's going to be some people that are exceptional at reading the radiology and some people that aren't. I think we have an opportunity as surgeons because we can look at the radiology and then we can go in and operate on the patient and then you can really correlate. The question is how often do you really do that in an organized manner?
And I think that really is a testament to the minimally invasive evaluation of these patients
I
and
agree.
having either a two-step process or time set aside to do a combined procedure. Combined meaning minimally invasive to conversion to maximally invasive.
We still struggle with that though, because patients would like to have everything done at one time. But there is some benefit to doing a two-step procedure when you do the laparoscopy and then subsequently operate on the patient. And not the least of those is the ability to counsel the patient, because if you've identified, say colon disease that's going to require, potential colostomy, it's really great to be able to tell a patient.
And we've had people
from
actually
the upfront.
declare want to go to neoadjuvant
That's
therapy
right.
specifically because they thought they were going to need to have
And
a
so we've had
colostomy.
patients that we've thought, okay, this patient could be debulked, but they absolutely were, no way am I having a colostomy.
Right.